a pleasure to introduce a new member of the Central New Jersey Greater Princeton medical community, Remington Brooks. Dr. Brooks is a trained general surgeon, did some additional training in transplant medicine at WashU in St. Louis at Barnes. I have a story that's rather that happened that he had to stop that due to a tragedy with his parents. He then left general surgery and was medical director for a Medicaid plan, and then decided he wanted to get back into clinical medicine and found his passion in wound care. The Wound Care Center, the Princeton Wound Care Center is founded by Dr. Haresh Kane. It is independent of any public company or anything like that. There was some conversation we were having earlier. It is, to my knowledge, the first one in the state of New Jersey dedicated wound care center. Dr. Kane, the founder, has an extensive experience in wound care, in long-term care and subacute care facilities around New Jersey. And again, we're delighted to have Dr. Brooks here to inform us about his work and the work of the Wound Care Center. Welcome.
Thank you very much. It is a pleasure to be here. I appreciate the opportunity to be able to talk to you. As was mentioned, I'm Remington Brooks, general surgeon by training, and found myself doing wound care. And it's a pleasure to be able to talk about wound care, which I kind of deem a sort of orphan child of medicine for many reasons, and we'll get into that in a minute. My only disclosure is the fact that I'm the medical director of the soon-to-open Princeton Wound Care Center, which will open sometime, hopefully, the 1st of January. This talk is going to be at a kind of a high level and a very broad look at wound care in the 21st century. Anybody know where this is?
Colorado.
Huh?
Colorado.
Colorado? Anybody else?
Utah.
Utah. This is the world's largest open pit mine, Kennecott Copper. 2 miles across, 1 mile deep. That's in the southeast corner or the southwest corner of the Salt Lake Valley. Utah, yeah. Now, let me start off by telling you a true story of my residency. When I started my residency in 1985 as an intern, surgical residencies were very traditional, very structured, very hierarchical, unlike they are today. We couldn't talk to the chairman of our department without going through one of the senior residents, for example. We had no responsibilities, but we had a lot of work to do. There was one exception, and that was they gave us a clinic. The interns were allowed to run a clinic. Talk about a great responsibility for an intern. It was a wound care clinic. Met twice a week, Tuesdays and Thursdays. And when it came my turn to run the clinic as an intern, I broke tradition, walked into the chairman's department office to thank him, had a prepared speech to thank him for this great responsibility. It included things like, I won't let him down, or what a great responsibility. And this was his response to me. The vast majority of wounds will eventually heal despite anything I did. That's not exactly what he said, though. This is what he said. Brooks, even you can't screw it up. And he didn't use the word screw. Now, he was correct on 2 accounts. The first being that wounds do heal. The body has this remarkable capacity to heal wounds, as you know. You get a paper cut, you don't have to get an amputation, it'll heal. Put a Band-Aid on it, put some Neosporin on it. Truth of the matter is you can soak that in ditch water and it's going to heal, right? Number one. Number two is, for those wounds that don't heal, it didn't matter what we did. Everything we did was anecdotal back in 1984. There was no research to support what we did. Wet to dry dressings was as sophisticated as we could get, right? And now we found out that doesn't work very well. So let's talk a little bit about the history of wound care and what we've learned over the years. Anciently, we used all sorts of different things. Some of them we still use. Honey, we still use. Maggots we could still use if it weren't for the aesthetics. It's the best debreeder we have, better than anything that's commercially available. Boiling oil, animal grease, leeches. These are all anecdotal sorts of things. But then in the 16th century, a very interesting surgeon by the name of Ambrose Paré did an experiment. As far as I can tell, it's the first experiment that was ever done, a study that he did. Let me tell you a little bit about Ambrose Paré. Ambrose Paré was a French Huguenot. He was a barber surgeon. He was very self-effacing. He came up with this quotation, "I dress the wound, God heals it," which would probably be over the mantle of every wound care center in the world. He was a battle junkie. He was a barber surgeon. He was a battle junkie. He liked to follow the French troops around. And so he created an experiment. During the Battle of Turin in 1536, which was more of a siege, it lasted for almost a year, he treated the soldiers with his traditional treatment, which was boiling elderberry oil, which he used to cauterize the wound. That was standard of care. Everybody did that, not just him, but all the other barber surgeons at the time that treated wounds used the same concoction. Well, before the year was out, he ran out of this stuff. And he had to come up with a way to treat the wounds. And he remembered reading something from Galen that included egg yolk, turpentine, and oil of roses that was put on cold. And so he had to switch to that because he'd run out of his other stuff. Now, Paré was an extremely he kept good records, and he watched these patients very carefully. And so the following day, he kept records of what happened, and he found in his study group that these patients were all in agony. They had secondary injuries, they developed infections, they took a longer time to heal, if they healed at all. And his other group recovered because the antiseptic properties of the turpentine, probably. Well, so he wrote it up, and he actually published it. And that became the new standard of care in the 16th century. Then not much happened until the 19th century, until Pasteur, Semmelweis, and Lister, and some of those people developed the germ theory. And then about the turn of the 20th century, and these are, I just mentioned these two because you're familiar with them, Dakin solution and Unna boots. Paul Unna was a dermatologist in Germany in the late 19th, early 20th century. Any dermatologists here? Okay. Then I'll say what I was going to say. He didn't like changing wounds every day. He wanted something he could do weekly instead of daily. So he came up with an Unna boot, which is basically gauze impregnated with calamine lotion and zinc oxide, which is essentially the same Unna boot we use today. Henry Dakin was a graduate student in biochemistry at Leeds University in 1910. Graduated, got his PhD. His first job was at Columbia University in New York City. So he immigrated and hooked up with a man by the name of Alexis Carrel. Anybody familiar with Alexis Carrel?
Vascular surgeon. Vascular surgeon. Right.
Second Nobel Prize winner, surgeon, to win the Nobel Prize in 1912 for his vascular. Exactly. Exactly. Well, he was working at the Rockefeller Foundation at the time, and the two of them were assigned by the Department of War of the United States to go to Europe to develop ways to treat wounds in World War I. And these mostly wounds were not battle-induced wounds. They were from other things, trench foot and things like that. Well, they came up with Dakin's solution, which is basically dilute Clorox. I mentioned Alexis Carrel. He's one of my favorite people as well. There was a young, in the 30s, there was a young engineer whose sister-in-law had congestive heart failure and wanted to do something for heart disease, create something for heart disease. So he approached Alexis Carrel, and together they built this contraption you see here. This is a Time magazine cover, 1938, I believe. This contraption is the first heart-lung bypass machine that actually worked in dogs. Anybody, and that's Carrel with the funny hat on. Anybody recognize the other guy? That's Charles Lindbergh. The two of those developed the first heart-lung bypass machine together, which has absolutely nothing to do with wound care. In the 50s and 60s, wet to dry sort of became the fashion. Different kinds of fabrics were developed for wound care. And then finally, 1990, the 1990s, serious research started to be done in wound care. You can see how late this is compared to other things in healthcare. This is the year I graduated from my residency, 1990. When I graduated from my residency, there were probably 24 wound care products that you could order. You know how many there are today? 5,000. Over 5,000. There are over 24 categories of wound care products. Okay? So let's talk about wounds. Even Shakespeare knew that wounds healed in stages. How long does it take a wound to heal? And by that, what I'm asking is, from the time the injury of a paper cut occurs till the time that metabolic process, that hyped up metabolic process we call wound healing, finally goes back to normal. How long does that take?
3 weeks. 6 months.
3 weeks, 6 months? 2 years. 2 years. And it goes in stages. Of course, about 90% of it occurs within the first 3 months, 6 weeks to 3 months. These are the stages. I'll go through them really quickly. You're probably familiar with them. Clotting stage, which lasts, less than 10 minutes in a normal person. I won't go through the clotting cascade, but during that process, a bunch of things are released that cause the onset of the second stage, the inflammatory stage. Now, the inflammatory stage is a very important stage. It starts within minutes of the injury. It goes on for up to 2 weeks. Normally, this is a normal wound process. The things that occur during the inflammatory stage is this hypermetabolic process where it's cleaning up the wound. You're getting an influx of all sorts of different cells, phagocytes and different kinds of PMNs and different kinds of cells that come in and clean up the wound and prepare it for healing. Then it goes into the proliferation stage where a lot of collagen is laid down, fibroblasts are proliferate, you get angiogenesis and a bunch of other processes going on, and that goes on, as you can see, for up to a month or more. The thing that takes up to 2 years, of course, is the remodeling stage. And that's a very, very slow process, and that can go on up to 2 years. When type 3 collagen is replaced by type 1 collagen and scars form and change. And that's a normal healing process, but we deal primarily with chronic wounds.
How do you define that? I mean, is that have a break in the skin, or is that like an internal wound that from blunt force trauma? I mean, is that any
kind of wound? Any kind of wound.
2 years. Yeah. So somebody who's involved in any kind of contact sport is constantly, in some kind of state of wound.
Yeah,
All right.
Okay, we're dealing with chronic wounds, and a chronic wound is arbitrarily defined as a wound that doesn't heal after 30 days, or at least appear to start healing after 30 days. Most of these, the vast majority of these, are stuck in the inflammatory stage for a variety of reasons. And our job as physicians is to figure out why they're stuck in the inflammatory stage and to kickstart them into the proliferative phase. Currently, in the United States, there are almost 6 million people with chronic wounds. 6 million people, that's 2% of the population. So 50 people, one of them has a chronic wound. This is interesting. In 2010, $20 billion were spent in the United States treating chronic wounds. 6 years later, over double that is spent, 50 billion, and I'm sure there's going to be more of that spent this year. Diabetes ulcers are increasing at 9% a year, almost 10% a year. Venous stasis ulcers are rising at 6 to 7% a year. I haven't included on here pressure ulcers. Population's getting older, more immobile in some cases, and they represent about half these wounds. About half these wounds are pressure ulcers. These are some of the reasons wounds don't heal. I'm not going to go through all of them, but you can see age is one, diabetes. You can predict the sorts of things that keeps wounds from healing. Let's take a sort of a veer off the track here and talk about oxygen in wound healing, the importance of oxygen, talk a little bit about hyperbaric oxygen. Oops. Oxygen does a whole bunch of things. Now think about this. You have somebody that is walking around normally, doesn't have any wounds, everything's going fine, then they damage their skin and cause this hyperactive inflammatory stage of wound healing to occur. If they barely have enough blood flow to that site to maintain their skin, and then something like that happens that requires this increased need for metabolic activity, and they don't have the capacity, it's not going to heal. And a lot of those patients that you saw on the previous slide, the diabetics and the vascular patients and some of the older patients, are in that state. And oxygen is important for a number of things in the wound healing process, particularly in that inflammatory stage. For PMN killing, for neovascularization, for fibroblasts to proliferate, and especially for collagen deposition. Every stage of collagen formation requires an oxygen molecule. So if you're making tons and tons and tons of collagen, and you don't have the oxygen capacity to supply that, it's not going to happen. It's not going to heal. Hence hyperbaric oxygen. Think of oxygen in this setting as a drug. As you know, drugs have a certain therapeutic threshold that needs to be maintained. If you don't get enough of that drug, it doesn't do its job. If you get too much, it can be toxic. You have to be right in that thin area. Now, you have to think of oxygen in terms of partial pressures instead of saturation for wound healing. We're sitting here in this room, our saturations, most of you are over 95%, probably higher. So giving you supplemental oxygen is not going to really increase the efficiency of wound healing. You have to increase the partial pressure. What's the partial pressure of oxygen in the lung for most people? I'm not a pulmonologist. There's got to be a pulmonologist here.
What's the partial pressure of oxygen in the lung? 90? I don't know.
100?
100? I don't know.
It's about 80 millimeters of mercury, right? Am I wrong? It's about 80 millimeters of mercury?
About right.
Yeah. Take a blood gas. What's the partial pressure on a blood gas?
21% of 760. So that's about
Oh, don't do that to me.
Anyway.
Okay. Okay. So let's say you're starting a normal partial pressure of oxygen is about 80 millimeters of mercury. Okay. We have a little machine called a TCOM, which is a transcutaneous oxygen monitor, that we can put on a wound and tell you what the partial pressure is at that site. And we have discovered that if it's less than 40 millimeters of mercury, that wound's not going to heal. That wound's not going to heal. Then you throw them in the hyperbaric chamber, do that again, and that can get up to almost 200 millimeters of mercury at about 2 atmospheres. Okay. And that's a predictor of whether or not hyperbaric oxygen is going to work. So you're delivering high pressure oxygen, 100% oxygen under pressure. All right? And that then pounds the oxygen into the plasma. And that's how that works, yeah.
So what's the mechanism of the monitor? How does it work? I know how an oximeter works. I'm not sure how this works.
When do you guys know how to do that? How it works?
The TCOM heats up the surface tissue, the capillaries release oxygen and CO2. across the skin barrier, which is picked up by a Clark's electrode, which looks at the difference in transport of ions between silver and copper, I believe. And it's proportional to the partial pressure of oxygen.
These are, I'm going to list the indications for hyperbaric oxygen. Most of these, we won't use it for these because they're, as you can see, most of them are acute care problems that need to be done in a hospital. But decompression sickness, which was the original use for hyperbaric oxygen, cyanide poisoning, you can go through those. These are the ones an independent wound care center will use it for, outpatient wound care center, are the following primarily. Osteoradionecrosis. Think of this, somebody's had radiation therapy, say mantle radiation for thyroid cancer or head and neck cancer of some kind, and they're anticipating having some oral surgery. Well, as you know, radiation over time destroys small blood vessels. And they have a chance of either developing spontaneous ulcers and wounds on the areas of radiation, or if something damages it, like surgery, they're not going to heal it. Hyperbaric oxygen is a indication for that. Either the best way to do it is if you anticipate there's going to be surgery, give them several trips to the hyperbaric chamber, plan the surgery around that, have them come back out and complete their hyperbaric training. Preservation of threatened grafts or flaps. I'm sure if there are any surgeons here who do skin grafts or who do flaps, that every now and then they see that a flap is becoming ischemic and it's going to die, and there's nothing they can do about it. Well, one thing, if they catch it early, hyperbaric can preserve that graft. Chronic refractory osteomyelitis, unresponsive to conventional medical therapy. Now, medical therapy is what for myelitis, osteomyelitis? Basically, it's 6 weeks of antibiotics. If that doesn't work, then hyperbaric is indicated. Now, it's been my experience as a surgeon, I have never seen a diabetic with osteomyelitis that has been cured by antibiotics alone. Now, maybe it happens. Maybe some of you have seen it happen. I personally have never seen it happen. So basically, a diabetic with osteomyelitis, after they failed antibiotics, he should get a chance at hyperbaric if you want to preserve that limb. Diabetic wounds of the lower extremities in patients who meet the 3 following criteria. Number 1 is obviously they have to have diabetes. 2 is they have to have a Wagner's 3 or greater ulcer on their extremity, lower extremity, and I'll show you what that is in a second. And 3, again, they've had to fail adequate therapy, which again is what, 6 weeks of antibiotics and wound care. Wagner's 3, you can see down here in the left-hand corner, basically is a deep ulcer with cellulitis, abscesses formation, and a lot of time osteomyelitis. It's a Wagner's 3. I'll give you 2 studies that have been done on, these are kind of the seminal studies that have been done on hyperbaric. Amputation rates in diabetic foot ulcers without hyperbaric oxygen can be as high as 40%. With hyperbaric, you can cut that almost in half, 23%. It's not a magic bullet. It's not going to cure everybody, but it's going to preserve some limbs that weren't preserved before. Wound healing alone in some of those ulcers. Non-hyperbaric, only about less than 1/3 of those will heal. With hyperbaric, you can get almost half of them to heal. Absent from hyperbaric indications, these are things you do not put people in the chamber for. Just a cutaneous wound, that paper cut I was talking about. Pressure ulcers alone aren't indications for hyperbaric. Now, if there's an osteomyelitis or if there's a flap that has been created and it's not going to heal, then maybe. But just pressure ulcers alone are not an indication. Stasis ulcers. We're going to talk about those in a second. Venous stasis ulcers and things like that. Chronic peripheral vascular insufficiency. Just because they have vascular disease and an ulcer doesn't mean that they're candidates for hyperbaric oxygen. And certainly not autism, by the way. We're going to talk about some chronic wounds now. Diabetic vascular wounds, I clump those together because the pathophysiology is pretty much the same. Neuropathic ulcers, diabetic ulcers, even though they're still a diabetic ulcer, they have a little different pathophysiology. Hydrostatic ulcers, that's a term I've sort of coined. I use it to refer to both venous insufficiency and lymphedema ulcers because they're primarily the same kind of ulcer. Premature ulcers, and of course surgical wounds. So arteriovascular, diabetic ulcers. The first thing you need to do with a diabetic ulcer is do a vascular evaluation, or a vascular ulcer is do a vascular evaluation. And what's a vascular evaluation? Well, it starts with peripheral pulses. Take their pulses. See if you can figure out just clinically what the flow is like in that extremity. ABIs, and when I say ABIs, there are ABIs and there are ABIs. I mean good ABIs, people who are trained to do them with good equipment, not just somebody that happens to have a little thing you can wrap around an ankle and figure out what's, blood pressure is.
What's an ABI?
What's an ABI? Ankle brachial index. You take a blood pressure in the arm, you take a blood pressure in the ankle, and you do a ratio of the ankle over the brachial, and if it's less than about 0.8, then you have bad flow in that extremity. Very simple test to do, very simple test to do. Color flow Doppler, very non-invasive, get a lot of good information from it. Of course, angiography and CT angiography. And if it can be revascularized, then you revascularize it. You have to rule out osteomyelitis. Well, how do you do that? Well, plain films. Start with plain films. Plain films are great for osteomyelitis. The only problems with plain films is they have a lag time from the time the injury occurs to the time they can develop changes in their plain film of about 6 weeks. Bone scans are great for looking at metabolic activity in the bone that would indicate an osteomyelitis. Ultrasounds are good for looking at the stuff going on around the bone, whether or not there's an abscess or a fluid collection or an edema of some kind. CT scans are universally worthless. Don't do a CT scan. MRI is the gold standard. MRI is the gold standard. Oh, I keep pushing on one button. I'm sorry. You don't want to see this thing twice, do you? Okay, so the first thing you do is you treat the vascular disease. You're not going to heal a wound if you can't get blood supply there, or some kind of, and if you can, it's going to be a lot easier. So some kind of, if there's any question at all, make sure they get seen by a good vascular person that can revascularize the leg if it's appropriate. You have to treat the infection. If there's an osteo or any of the cellulitis around the wound, you have to address the wound itself. You have to debride the site, different kind of dressings you can use, that sort of thing. And finally, hyperbaric if it's appropriate, if it's indicated. Neurotrophic ulcers. That wound care clinic I told you about as an intern, the first patient I saw as an intern gave me this story. He's a young guy, he's like in his 30s. I saw him on a Thursday. He had been a lifelong diabetic, type 1 diabetic, had been walking around the beach in Hammonasset, Connecticut, and in a barefoot, mistake number 1, diabetic walking around barefoot on the beach. Number 2 is he didn't check his feet until Wednesday. And when he looked at his foot, that was mistake number 2. When he looked at his foot, he found a thumbtack in the bottom of his foot. When he pulled the thumbtack out, he saw one of these. This is a classic story for a neuropathic ulcer. Diabetic that injures his foot and doesn't recognize it for a long time. Again, that little wound there you see doesn't look too bad, but many times there's an underlying osteomyelitis, so you have to evaluate for that. So you treat the cause of the problem. You take out the thumbtack. Most of the time, though, it's something like a pair of shoes that don't fit right, or a bony prominence, or it could even be a Charcot joint that needs to be addressed by a podiatrist or somebody that can fix it. But whatever is causing it, has to be fixed. Of course, it's their neuropathy that's causing the problem. They don't feel the injury, and they just keep injuring it over and over again. And so it builds up this callus, and it develops this ulcer. The treatment is to totally offload that. The standard of care is what's called a TCC, a total contact cast, which is just a cast that totally takes the pressure off that wound. They've used cam boots in the past, with some of them been effective, and sometimes patients refuse to wear the cast, and so you have to resort to cam boots. But the standard of care is a total contact cast. Again, treat the osteomyelitis, manage the wound bed again, including getting rid of that hypertrophic skin around the wound bed that's built up. That has to be pared down. Again, hyperbaric if appropriate if there's an osteo. Hydrostatic disease. Of course, there's two kinds, as I mentioned. There's venous stasis and lymphedema. Venous stasis has that, they both usually have these very swollen legs with a lot of exudate, and the wounds look pretty much the same. They're on the lateral aspects, typically maybe over bone. Bony prominence, they can be very shallow. The lymphedema, or the venous stasis disease has that characteristic brawny induration from hemosiderin deposits, but they're treated pretty much the same. With the venous stasis, you want to rule out possible clot in the thrombus in the legs that might need to be treated. Lymphedema, you want to work up the cause. The imaging used to be lymphangiogram. Now they can pretty well evaluate it with ultrasound. First thing you want to do with hydrostatic disease, if it's venous stasis disease, of course, is to rule out DVT. Wound bed care, again, as I said before, these are very shallow. You want to control the infection. They can be very exudative, moist, particularly if they're starting to diurese, and so that can be very challenging. So you have to plan your dressings accordingly. Vein ablation sometimes is a good thing. So one of the things you might want to do is refer him to, again, to your vascular guy to look at him to see if some sort of vein ablation would be appropriate for that particular patient. The most important thing for these wounds, though, is compression. Compression. By compression, and this is what I tell them. Once it's healed, there's two things they never do again in their life. They never just stand, and they never just sit. They get up in the morning, they put on their compression stockings, and then if they have to stand, they march in place. If they have to sit, they put their leg up. If they're on an airplane, every 15 minutes they get up and walk back and forth. These are the compression stockings. The best ones are the tailor-made ones. There's all sorts of different styles out there, but it needs to have at least 30 to 40 millimeters of mercury at the ankle, graduated compression on the way up. Once in a while, they're probably candidates for thigh-high stockings. The problem is I have never had a patient who would wear them. Never. Anybody try to get a patient to wear thigh-high stockings? Do they wear them?
Had to, and he did.
He did? Good for you. You know, I need to talk to you. Because I've never had a patient. We'll get them for them. They'll get them made, and they'll use them for a week, and they'll say, "I'll never wear those again." So,
He had no vena cava.
huh?
He had no vena cava.
Oh, they couldn't put a filler in?
No, there was no vena cava at all, and he had no choice.
Okay, well, good for him. I'm impressed. I'm going to send him a thank you note.
What the rationale for the vein removal?
It removes some of the pressure in the system. Got to keep their legs clean away. I tell them to get up in the morning, grease their legs down with some kind of ointment. It doesn't matter what it is, as long as it doesn't have a scent. It can be the cheapest stuff they can get at Walmart. They put on their stockings, and that's how they start their day. That's the rest of their life. That's what they do the rest of their life. Pressure ulcers, decubitus. Localized injury to the skin, usually over a bony prominence. You can predict where these ulcers are going to occur. Let me ask you this. You had Thanksgiving. So you ate the meal, after the Thanksgiving, you watched the football game, right? How many watched the football game? Anybody watched the football game? Anybody fall asleep during the football game? You fell asleep? So you're sitting there for how, about 3 hours? How? Okay, we'll come back to that. It's a tissue ischemia causing tissue breakdown. There's shearing forces involved. It's in a moist, wet area. Sometimes there's feces and urine that exacerbate it. As you can see, you can predict where these are going to be. And bony prominence where there's pressure for periods of time. Okay, here are the stages of pressure injury. Stage 1. At the end of that football game, you had a stage 1 pressure ulcer. I can guarantee, because I did. I fell asleep, and I got it hurt back there. That's stage 1, basically. It's just a little redness over the area. There's no visible damage that's done. Stage 2 is through the epidermis into the below the dermis. Stage 3 is down into the muscle, and stage 4 is all the way down to the bone. The best thing is prevention. Maintain a moist environment. Use an inclusive or a semi-permeable dressing to protect the area. And of course, stage 3 and 4 you need to actually do some debridings and some wound bed care, and sometimes even surgery is necessary. And by surgery, I mean serious surgery, flap surgery. Now, I show you this picture for one reason. You see what an elegant job has been done to fix that. I mean, that's a stage 4 decubitus that has been, they've done a very elegant job of flapping that. I guarantee you put that patient back in the same environment, that flap is gone in a couple hours. Regardless of how well that flap's done, you put them back in the same environment, that flap will break down within a couple hours. So all that work will go in place. Surgical wounds basically needs debridement, control of the wound care bed, negative therapy pressure, basically wound vac sort of thing. A wound vac does several things. They're good for open abdominal wounds, they're good for diabetic foot ulcers, they're good for pressure ulcers, and for fasciotomies. They're almost de rigueur for fasciotomies and both of, fasciotomies. They provide a moist environment for healing. You know, this idea of wet to dry, dressing changes, dry wounds are not a good thing. Moist wounds are good. Wet wounds are bad, dry wounds are bad, moist wounds are good. It increases blood flows, and it stimulates growth factors, white blood cells and the like. My watch isn't working. What time is it?
8:41.
8:41, okay. So we have a few minutes left. Let's talk a little bit about biofilm. Biofilm, which is a scourge of wound care. Anybody see Star Trek? You know who the Borg are?
Yes.
Who are the Borg?
They take over your whole self, that implant something in you.
Yeah, they're able to communicate through, all the Borg are able to communicate with each other, you know? Anybody, there are more Trekkies in here than want to admit, right? Okay, so anyhow, biofilm, think of biofilm as the Borg of microbiology. This is two definitions of biofilm that I got from two medical dictionaries. I picked the first one because I love the fact that they use the word slimy in a medical dictionary, slimy. But basically, it's a slimy matrix of extracellular polymeric substances. And as you can see in both these definitions, they use the term polymer or polymeric. Those are important in biofilm, and they're usually multi-organism. They form that slime that they have is a polymer, and that polymer is a way they communicate with each other. They stick. They're multi-microbial. Things that don't typically exist together now live together in this community, including bacteria, fungus, They're symbiotic, they help each other out. They assign each other different responsibilities. They're very kind of frightening. They communicate with each other through that polymer. They are resistant to both oral and topical antibiotics. And they're able to overcome localized host immunity. So the typical things like in that inflammatory stage of wound healing that occurs can't occur here. They start off as anybody play that game? I think it's called Sim City, where you start out with a bunch of cavemen and you end up with like Manhattan at the end of the game. Well, that's the way these things form. They start very slowly, and over time they become very, very, very complicated and very, very sophisticated, to the point where they can actually metastasize. Some of the biofilm you're familiar with is plaque on your teeth. That's a biofilm. Cholera is a biofilm of the GI system. Legionnaire's disease is a biofilm of the respiratory system. They can occur on implantable devices. You can actually go out and see them if you go out in the countryside and look at water pipes, you can see biofilm build up on that. They like orthopedic hardware and catheters. Now, there are some dressings that treat biofilm, particularly ones with silver in it. They're trying to develop these all the time. None of them are very good. The best way to deal with biofilm versus debridement. And that's about all I've got, I think. Yeah. Any questions?
I guess a couple of questions. First of all, could you talk about how you do hyperbaric oxygen planning? So how many sessions?
That's a good question. That's a good question. I can tell you how sort of the standard of care is, and then I'll give you a little brief insight as to how we got there. Typically, first of all, you evaluate the patient, see if they fit the criteria. And then you look at their ears. Some people will get a chest X-ray on everybody. Other programs will do it selectively. Primarily, you're looking for something that would cause a problem, pulmonary problem, particularly a pneumothorax. If they've had a history of pneumothorax, or they have something that would indicate that they might have a pneumothorax. You don't want that to happen. If they're candidates, then they typically are exposed to about an hour and a half in the chamber at about 2 to 2.5 atmospheres with what's called a oxygen break, someplace in the middle. And they typically get about 30 sessions of that. This is say for one of those Wagner's 3 foot ulcers. That is a typical course of treatment for a hyperbaric patient.
30 sessions on each day?
Every day, 5 days a week. 5 days a week. 5 days a week. The way they came up with that, and one of my colleagues here could probably be a better person to explain that, is research in hyperbaric is in its infancy. And at some point in the future, we may discover that there are better ways to treat different kinds of patients. But right now, those are the studies that have been done. There haven't been a lot. They've been very conclusive for what they have been, but it needs refinement. It desperately needs refinement as far as how we treat hyperbaric patients.
And when someone's in a course of treatment, is there a prediction of how well they will do after a week, 2 weeks?
It takes a couple weeks. Sometimes you can tell. Like I say, you saw the statistics there. Not all of them are going to work. Maybe half of them it's going to work on. And you can get some idea. Sometimes you get a response. It's a late response, so you'll subject them to another series. Sometimes you'll get halfway through and say, this isn't working, and we're okay.
And I assume if they fulfill certain criteria, this is covered by insurance?
Yes, all those things that, if they meet the criteria that has been set up, it's paid for by most insurances. Yeah.
20 or so years ago, I was introduced to a Long Island company that uses some kind of platelet-derived growth factor. And just wanted you to comment on that, but also not only on that, but other kind of growth factor related wound acceleration healing?
Yeah, that's a we can go another hour on that. The platelet-derived growth factor is now used for just about everything. From somebody, my daughter lives is a runner. She lives in Texas, and some podiatrists try to talk her into having it done for her plantar fasciitis.
Right.
And insurance didn't pay for it, so she's going to shell out like $2,000 for this treatment. So it's used for a lot of things. Many of them hasn't been really. In fact, there is a manufacturer that provides in your office a wound care clinic and make their own platelet-derived growth factor and inject it into a wound. I've never done that. I think that we have products that are more inexpensive, just as effective, as far as I can tell, as far as the literature goes, and a lot easier to apply. Those products would include things like collagen grafts, or there are actually cell grafts you can put down that they're used either placental derived cells. The oldest one is actually derived from a clone of foreskin. So it's the same clone of foreskin that they're using for these cell-derived. They're grafts basically that you put down that stimulate growth. They have fibroblasts in them. They have all sorts of growth factors in them. Different ones have different kinds of growth factors. To my knowledge, at least in my experience, most of them work about the same. The problem with wound care, as I mentioned before, is we're still in the infancy. We see this inflammatory stage here that is an incredibly complicated set of things that are occurring, and we try to provide the things that the inflammatory stage has in it, the fibroblasts, the collagen, but we don't know specifically in that particular wound which molecule is missing. At some point in the future, we're going to be able to do that. Right now, we're just sort of shotgunning it with all these different sort of products, and we're not really good at it yet. We're better than we used to be, but we're not really good at it yet. And that's why I call it the orphan child. We haven't really scratched the surface of what needs to be done in wound care.
I'm sorry, I know that I'm a cardiologist, so cardiology does a lot more evidence-based stuff. So how good is the evidence that hyperbaric?
For those indications, it's very good. For those very specific indications, it's very good. And it doesn't work for autism. It doesn't work for most of it, for whatever Michael Jackson was using it for. It doesn't work for those things. It does work for those very, very specific indications. There are going to be more indications come out. For example, when we talk about preserving skin grafts and flaps, there's been no research in this, and there should be, but it would probably work well with these artificial grafts too, in these patients that have poor flow in their extremities. Putting an artificial graft down, putting them in the chamber, and seeing if that doesn't help. They're doing research in that.
Those studies are being done?
Huh?
Those studies are being done?
Yeah. Traumatic brain injury. There's some great studies that are being done in Israel and other places on traumatic brain injury. We'd like to get involved in some of those if we could. But for the stuff that was on that list, that's all very well documented. That's all FDA approved, very well documented. Now, I can't speak to everything that's on the list specifically because I don't treat, hearing loss or...
Right, acute sensory neural.
Yeah.
In the OBGYN arena, we have phenomenon that sometimes occurred. That is, for example, a woman has a delivery and either declines or the doctor, whoever delivers her, does not do an episiotomy. And she has a horrendous tear that you cannot fix. Because every time you put in a stitch, you tie it, and it rips right through.
Right, it's like, yeah.
What I was taught in my residency days, which I finished in '82, just applying estrogen to that perineum, and it heals rather nicely. And I have an experience of a quadriplegic patient. He was not my patient, but his wife was. And the biggest problem they had those pressure ulcers on this poor man. Estrogen worked on those pressure
On
ulcers.
him, see, we don't know at a molecular level what a specific wound needs. So, like I say, we throw all this stuff at it that we think most wounds needs, and it works a lot of the time, but not all the time. So we're certainly not there yet.
Thank you very much.
Thank you.